Hello, and welcome to the Pediatric Brain Tumor Foundation's webinar, Understanding Endocrine Problems Following a Pediatric Brain Tumor Diagnosis. My name is Heather Held, and I am the National Family Support Programs Manager for the Pediatric Brain Tumor Foundation. We are honored to have you joining us today for this very important webinar. The PBTF provides programs and resources to support our families facing a pediatric brain tumor diagnosis throughout their journeys. We will provide links to some of those programs and resources at the end of today's webinar, as well as in a follow-up email. Before we get started, I do have a few guidelines to review. You are muted for this webinar and your video is disabled, but we welcome questions during and after the opening remarks. Please type your questions into the Q&A feature found at the bottom of the Zoom window. We will not get to every question, but we will try to answer as many as possible. Today, we'll hear from our presenter, Dr. Briana Patterson, and then a parent will join her for a panel discussion. Kathy Riley, our Vice President of Family Support, will host the Q&A portion of our webinar. Dr. Patterson is originally from Alabama, but attended college in Texas and her medical school at Emory in Atlanta. She completed residency in general pediatrics in 2006 and her fellowship in pediatric endocrinology in 2009. Since then, Dr. Patterson has been a faculty member in the Emory University School of Medicine and a clinical endocrinologist with the Aflac Cancer and Blood Disorders Center at Children's Healthcare of Atlanta. Additional roles at Children's include medical director for the Pediatric Thyroid Cancer Program and program director for the Pediatric Endocrinology Fellowship, a program to train new endocrinologists. Dr. Patterson has 13 years of experience caring for pediatric brain tumor patients for their endocrine problems and has worked with Children's Oncology Group, as well as international consortiums to help develop guidelines for the identification of endocrine complications of cancer treatment. On a personal note, Dr. Patterson has 2 children and enjoys hiking, gardening, and knitting in her free time. It gives me great pleasure to introduce to you today, Dr. Briana Patterson.
Heather, thank you for that kind introduction, and thank you everyone who's been able to join us today for the webinar. I appreciate you sharing some of your time with me today to talk about the endocrine problems that we see in children who have faced brain tumors. It's a great pleasure and great honor to be with you, so thank you. You can advance the slide. We're going to have 4 main topics today. We'll talk about some general principles of endocrine care, specifically about growth hormone, reproductive hormones, and fertility, and have some focus on wellness, metabolic health, and obesity. Next slide. People often ask me the first time they see me, what is a pediatric endocrinologist? And I sometimes joke with the patients that they probably have never seen one before, not even at church or Walmart. But a pediatric endocrinologist is a specialist in hormones, and that can include pituitary and hypothalamic function, growth and growth hormone, puberty, thyroid disorders, issues surrounding blood sugar, metabolism, and diabetes, bone health, particularly bone density and bone strength, and adrenal gland function. Next slide. The endocrine system is very interconnected, and this slide just begins to kind of give you a flavor for that. But as we talk about issues of growth or thyroid, puberty, and bone health, there are many endocrine systems that are giving input to each other to allow for everything to happen properly and normally in a growing and developing child. And additionally, non-endocrine factors such as nutrition and diet play a role as well. Next. This slide is a classic depiction of pituitary function, which is one of the main aspects of endocrinology that's relevant for our pediatric brain tumor patients and survivors, and depicts the pituitary gland at the top of the slide and the major functions that it has, which include controlling the thyroid, controlling the adrenal glands, which are located in the abdomen on top of the kidney, production of prolactin, a hormone that's particularly important during pregnancy and lactation, production of growth hormone to promote growth in height or statural growth, production of the gonadotropins, which are responsible for controlling the ovary and the testes, regulating the production of sex hormones, but also regulating the production of sperm and eggs. And then the posterior pituitary is responsible for helping to regulate water balance in the body via a hormone that's called antidiuretic hormone, production of oxytocin, which is relevant for labor, lactation, and also relevant for some aspects of human behavior and human bonding. Next slide. I often get asked the question, well, you know, do we need to see a pediatric endocrinologist? Or if my child had a brain tumor, you know, how would I know if they might have an endocrine problem? And there are some very well-established risk factors for endocrine problems for pediatric brain tumor patients and survivors. The presence of a tumor with an anatomic location in or very near the pituitary and hypothalamus. These can cause endocrine problems with or without a surgical resection. These tumors may include craniopharyngioma, pituitary adenoma, germ cell tumors, optic pathway tumors, hypothalamic glioma, and others. But those are the common tumor types that you might find in that location. Very frequently, patients with tumors in those locations can have endocrine problems even prior to diagnosis of the tumor or prior to tumor treatment. There are other types of pediatric brain tumors that can also result in endocrine problems, and these are those that may be anatomically remote from the pituitary and hypothalamus, but are frequently treated with radiation therapy, which can affect the pituitary and endocrine function. So for example, if there's radiation therapy to the whole brain and spine, if there's radiation therapy that's given to a pituitary or hypothalamic focus, or if there's a tumor that receives focal radiation, if the tumor happens to be relatively close to the hypothalamus and pituitary where there is scatter of the radiation. And the most frequent example of these tumors that are remote from the pituitary but still result in dysfunction at times would be medulloblastoma. Chemotherapy can also cause endocrine dysfunction, particularly alkylating chemotherapy can affect the reproductive organs and their function. And now there are some emerging immunotherapies, which are not currently in common use for pediatric brain tumors, but are more commonly used in adult cancer that can also affect endocrine function. We may see those therapies move into pediatric use in the coming years. That's why I mentioned them. You can go to the next slide. Another way we can think about which kids could be at risk would be just by diagnosis. So here I listed the most common brain tumor diagnoses that I see in my endocrine clinic and what types of endocrine problems they have. So my medulloblastoma patients may have growth hormone deficiency or thyroid dysfunction, and sometimes they have reproductive health problems as well. Craniopharyngioma patients may have hypopituitarism, diabetes insipidus, and hypothalamic obesity. Pituitary adenoma patients may have high levels of pituitary hormones if their tumor is functional, and they may also have problems with their reproductive hormones, which we call hypogonadism. Optic pathway and hypothalamic tumors tend to have problems with thyroid growth. They may have hypothalamic obesity, and many of them have alteration in pubertal timing, including early puberty. Germ cell tumors present with endocrine problems that are very similar to craniopharyngioma, hypopituitarism, and hypothalamic obesity. And there are other types of tumors that I do see from time to time as well with endocrine issues, including ATRT, ependymoma, pineoblastoma, and DIPG. This isn't in a totally inclusive list. There are probably other types of tumors that I see, but this is the most common things and common presentations in my clinic. Next slide. Another question people ask regularly is how long will endocrine care last? And the reality for the majority of these hormone deficiencies, particularly if there is a true issue with pituitary dysfunction or end organ dysfunction, like thyroid gland dysfunction or ovarian dysfunction, for example, in many instances, the hormone deficiencies are permanent and lifelong therapy may be needed. And this is particularly true for things like hypothyroidism, adrenal insufficiency, and diabetes insipidus. There are some endocrine treatments that might be shorter term, and by shorter term, I mean over a few years, and maybe could be stopped. These include growth hormone therapy, and that is a very individualized situation. Sometimes it's a longer term treatment, sometimes it's shorter term. And also adrenal suppression coming from the person taking steroid medication. There are also other conditions that we think should be monitored for the lifespan, but might not require treatment. Go to the next slide. So thinking about that longer term monitoring, it's very, very helpful if patients who've been treated for a brain tumor have something called a survivor healthcare plan. This is something that you typically might receive after completion of therapies, and many centers do this 1 or 2 years after completion of therapy. It includes a medical summary about what the diagnosis and the treatments administered were. There's an individualized risk profile, details the type of health problems that can occur after the cancer treatment, including the endocrine problems that can occur, and a personalized surveillance plan that describes what tests are recommended to screen for the problems, including the endocrine problems after the treatment, and how often those screening tests should be performed. This is a document that can be shown to primary care providers, to consulting physicians such as an endocrinologist, to really help them understand how best to monitor a young person after they have completed treatment for their brain tumor. Next slide. We'll move on to growth hormone next. So what is growth hormone and growth hormone treatment? Growth hormone is a peptide hormone that comes directly from the pituitary gland. It travels through the blood to the liver, where it induces the production of a second messenger hormone called IGF-1. And IGF-1 then goes to the bone and has a direct impact in the growth of height in particular. Growth hormone, generally speaking, does not really promote weight gain. It's not used particularly for problems like cancer-associated weight loss, but it's helpful for the promotion of height. Treatment for growth hormone deficiency is usually considered for children who've had a brain tumor and have demonstrated stability or potentially even cure for some period of time, usually 1 to 2 years, depending on the center you're being seen in. And also children who have a documented deficiency in growth hormone. Short stature can occur for many reasons, and short stature alone may not be an indication for growth hormone medication, but if they have a true deficiency, they can receive a daily injection at home. There's actually also a new option that was just approved last fall that's weekly. None of us have a lot of experience with the new weekly medication yet, so that more to come in the future on that. But it is exciting to think about maybe not having to have a shot every day. But growth hormone has a positive impact in addition to height on things like muscle mass, bone density, and potentially our cholesterol. So there are other long-term health benefits besides just increasing your height. Next slide. Growth hormone deficiency occurs in brain tumor patients, usually in association with certain risk factors. And the risk factors for this are very well established. It's pretty much radiation, in which case the higher the dose, the higher the risk, and the earlier the onset of the growth hormone deficiency. Growth hormone deficiency can emerge as early as 6 months after radiation therapy in high doses, or as late as 5 or 7 years after treatment in lower doses. Tumor location, particularly those tumors in the hypothalamus and pituitary, are also significant, well-established risk factors, even in a child who never received radiation. The evaluation for growth hormone deficiency consists of monitoring the child's growth on the pediatric growth chart. Blood tests can be checked, particularly to monitor the IGF-1 level. And growth hormone stimulation testing is a usually half-day test that's undertaken to more conclusively document the growth hormone deficiency. Bone age is an X-ray of the hand that can be done to try to better understand the child's pace and progress in terms of their growth and height relative to their peers. So we're able to see if the bones of a 5-year-old, for example, look like a 5-year-old, or if they look more like a 3-year-old or like an 8-year-old, because that would definitely impact our interpretation of their growth pattern. We talked already some about the consequences of growth hormone deficiency in terms of lean muscle mass, cholesterol, bone density, and height. But there are related issues here as well that are particularly relevant in our brain tumor survivor population. And that is that nutrition plays a very important role in pediatric growth. And without adequate nutrition, even very excellent growth hormone medication therapy cannot overcome nutritional deficiency. So very often I'm counseling patients not only about how to best use their growth hormone medication, but also about how to optimize their nutritional intake so that the medication can produce the maximal benefit. Secondarily, unfortunately, spinal radiation, which is commonly used for certain tumor types, has a direct negative impact on bone that impacts spinal bone growth independent of growth hormone. This causes children who've received spinal radiation to have somewhat less growth in terms of the spine itself. The spine cannot grow as well as other bones of the body, and growth hormone therapy cannot fully overcome that. So in that situation, we have to monitor for disproportionate growth. Next slide. This is just to give you an example of a pediatric brain tumor patient with growth hormone deficiency and what has happened with a little bit of treatment of that condition. This is a boy who was diagnosed with medulloblastoma around the age of 9.5. And you can see that he received treatment. During his cancer treatment, if you look at the chart on your right-hand side, you see that he did lose weight during cancer treatment, which we know is a very frequent occurrence, particularly with that diagnosis. After he completed his cancer therapy, he was able to gain weight again and return back to his baseline weight and gain weight appropriately after that. But despite having recovery of his weight after his cancer treatment ended, you can see on the left-hand panel that his growth rate slowed down and he lost his growth percentiles. He moved from being at the 25th percentile to being all the way down at the 5th percentile over the course of just about a year and a half or 2 years after his treatment ended. Because of that very slow growth rate, we were suspicious that he may have growth hormone deficiency induced by radiation. He was tested for that, a diagnosis was made, and he began medication. And you can see where it's marked in green that he started his medication and his growth and height has responded beautifully. He started growing at a much, much better rate, and he's, of course, still growing today. So our goal will be to get him to an appropriate adult height. Next slide. Very common question when I counsel families about the long-term risks of growth hormone therapy is, well, it's growth hormone, it makes things grow. So is it going to make the tumor grow? Is it going to make the tumor come back? And we have really very excellent long-term data looking particularly at recurrence of cancer in children who've been treated with growth hormone. And what they've found is that there is no statistically significant, that's a mouthful, isn't it? There's no statistically significant difference in the rates of cancer recurrence in children who are treated with growth hormone and those who are not treated with growth hormone. So we don't really worry about recurrence of primary tumors anymore when we give growth hormone relative to if we didn't. Early studies had suggested that there could be an increased risk for second tumors in children treated with growth hormone. But this is a really complicated issue because we said that radiation treatment is one of the major risk factors for growth hormone deficiency. We also know radiation treatment is a risk factor to develop secondary tumors. So when we have radiation causing the growth hormone deficiency and causing secondary tumors, it doesn't seem surprising that we might see a little bit more secondary tumors in kids who receive growth hormone. And indeed, over time, when this has been studied rigorously, we actually saw a decline in the risk associated with growth hormone and secondary tumors. And if you make an adjustment for the fact that they've received radiation and you compare based on the amount of radiation and radiation dose, it does appear that radiation accounts for that burden of secondary tumors, and there's no increase in the rates of secondary brain tumors, specifically meningioma and glioma, in children who've been treated with growth hormone relative to those who were not. Next slide. We'll change gears a little bit. We'll talk some about reproductive hormones and fertility. You can go ahead. When we think about reproductive hormones and fertility, we have to sort of think about, of course, the ovaries and the testes and what they normally do in their job. This is a cross-sectional picture of a human ovary that's been cut in half and kind of stylized so you can see what it's up to. It has some teeny tiny little primordial follicles that are just sleeping away and not even ready to develop yet. They'll develop in the future. It has some little, what I think of as kind of school-aged follicles that are moving through their developmental process, but not really close to ovulation or being mature. And then over on the right-hand side, you can see some mature oocytes that are more like your adolescents or young adults, and they're ready to go, including one oocyte that's been ovulated there. So the ovary generally, it's going to be housing the immature and the developing eggs, allowing them to develop and be released at the appropriate times. And then, of course, it's making the female hormones, estrogen and progesterone. Next slide. Similarly, we have some pictures here for the testis. The testis does things a little bit differently than the ovary. And in the ovary, it's really those oocytes and their surrounding cells that are doing all of the hormonal activity kind of together in concert. In the testis, we have two populations of cells. We have germ cells that make sperm and the Sertoli cells which support them while the sperm are developing. And then we have Leydig cells that are functioning relatively independently of the Sertoli cells, and they're making the testosterone. Next slide. So with our pediatric brain tumor population, there are really three potential developmental patterns for puberty. Puberty can be early, puberty can be on time, and puberty can be delayed or even absent. And so we'll talk a little bit about precocious puberty, and what that means is that you have pubertal development at an age that is younger than what is expected. So it's prior to age 8 in girls and prior to age 9 in boys. Typically, the risk factors for this include specific tumors in the central nervous system, especially those seen in the hypothalamus. So this can include hypothalamic hamartoma, hypothalamic glioma. Additionally, cranial radiation, particularly if there is more than 18 gray administered to the hypothalamus. That area is the sensitive area that needs to see the radiation. And then younger age of treatment, which is not too surprising, because if you're treated at a little older age, if you're already 8 or 9, then you won't have precocious puberty because you're already older. The screening for this is annual examination for puberty changes. And I really encourage families to not be too nosy with their kids, but to have a basic idea of what's going on with puberty, because if you observe something at home between visits, a year is a long time to go. So if you observe something at home that's changing between visits and your child is young, prior to age 8 or 9, then you want to give the doctor a call so you can be referred to the endocrinologist sooner rather than later. When I evaluate patients in the clinic, I'm typically measuring blood tests to evaluate the puberty hormones to confirm a diagnosis of precocious puberty. I'm doing a physical exam to assess their pubertal stage. So that's looking at breast development and pubic hair development in girls, and looking at the penis development and testicular development, as well as pubic hair in boys. And then doing the X-ray again, the bone age, which allows me to compare the pace of skeletal development to other average children and say, is this average development or is this development too fast? Next slide. Delayed and absent puberty are other common developmental patterns in our population as well. Ironically, the risk factors are actually very similar to the risk factors for precocious puberty. So sometimes I even see patients who have early puberty when they're very young, and then when the time is right and they're supposed to progress fully in puberty, they are unable to progress fully and completely later on. So the risk factors are very similar to precocious puberty, but in addition to tumor location and radiation, we have to add in gonatotoxic chemotherapy. So this is our alkylating chemotherapies, drugs like Cytoxan, procarbazine, and many others. We'll not list them all here. Additionally, radiation involving the ovary or testis. So sometimes we wouldn't think about radiation involving the ovary or testis in a child who survived a brain tumor, but if the whole spine requires radiation, there's the possibility, particularly with photon beam radiation, that the ovaries may have experienced some scatter radiation during treatment. The evaluation for this is also by good physical examination, at least annually. And if there's any question or concern about the pace or progress of a child's pubertal development, we can measure their hormones and consider obtaining the bone age X-ray as well. Next slide. Before I go on to fertility, I just want to comment that for both precocious puberty or early puberty and delayed or absent puberty, we do have very effective medical treatments available for those problems. So it's definitely possible to normalize a child's pubertal timing and experience relative to their peers. And this is often something that's really important to patients and families to feel like their developmental pattern is matching the other kids around them and to keep them socially appropriate in terms of their physical development. So we're able to help with that. There were quite a few questions in the pre-registration about fertility, so I thought I would address that a little bit. And before I talk about fertility in kids who've had cancer and brain tumors, I just probably do not have to remind the audience, but I will mention that about 1 in 10 couples overall in the United States report that they've had trouble conceiving. So these are not people who've necessarily had a brain tumor or any type of cancer, but infertility is a relatively common problem amongst couples who wish to have biological children. And I'm sure there are many people that are participating in the webinar today who may have gone through that experience. And so in terms of infertility, that means there are both cancer and non-cancer related risk factors. And I've listed some, but probably not all of the non-cancer related risk factors here. Sometimes with infertility, we don't even know the reason why a couple's having trouble, but it is a relatively common issue. When we talk specifically about people treated for pediatric brain tumors, the increased risk for infertility is exposure-based and also related to the type of tumor and the location. Alkylating chemotherapy, as I've mentioned earlier, is a very important risk factor, but does not universally cause infertility in every single person who receives it. Things like being a younger age and being prepubertal at the time of your treatment may be somewhat protective, and individualized evaluation is really needed to determine what's going on with any particular brain tumor survivor if they are concerned about the possibility of infertility. Tumor location in the pituitary or the hypothalamus or both can also affect a person's fertility and their reproductive function because the hypothalamus and pituitary have to send those signals to the ovary and the testis to tell them to make the eggs and the sperm respectively. Next slide. Good. So there are definitely options for this as well. And the options really depend quite a bit on the age of the child and sometimes on the level of medical urgency. I'm sure we have a very diverse group of families and patients and survivors participating today. And for some people, they may have learned of their brain tumor diagnosis as an outpatient and not had a lot of hospital admissions. Other people on the webinar today may have had the total opposite experience, and they learned of their brain tumor diagnosis for the first time in an intensive care unit. So there's such a wide range of experience, and that sometimes affects the fertility options. But generally speaking, there is pre-treatment cryopreservation of semen available for guys. This is only available for guys that have started puberty and usually progressed into the middle or kind of latter 3/4 of puberty. And so what they have to do is provide a masturbatory sample of semen that can be looked at in the laboratory to confirm the presence of sperm. And then if the sperm are present, the sample can be frozen for later use. This is also something that guys could consider doing even if they've been previously treated for their brain tumor, but find themselves in the position of needing additional treatment in the future. Right now, preservation of immature testicular tissue for younger boys who are either not in puberty yet or who have not progressed enough in puberty yet to do the semen cryopreservation is something that's still considered experimental, but that's in development, and we're really optimistic that that's going to become a reality in the not too distant future. Additionally, young men who have been treated in the past for a pediatric brain tumor may wish to consider a post-treatment semen analysis. But it's important that they understand that semen counts can drop during chemotherapy, and they may actually recover within the first few years after chemotherapy is completed. So they may not want to do this, the month after they complete their treatment. They may want to wait a little bit for recovery so that they can get an optimistic picture of their testicular function. Next slide. Girls have options too, girls and young women. They can consider pre-treatment egg freezing. Again, similar to the pre-treatment semen freezing for boys, the egg freezing is really only available for girls who've already gone through puberty and had their first menstrual period. This is a process that is identical to an IVF cycle that many adult women choose if they're having issues with infertility. So it's an invasive procedure. So then you also need to be old enough and motivated to participate in this. Very recently, ovarian tissue cryopreservation has become more widely available. It used to be considered experimental, but now more centers are offering it. And this can be performed even in younger girls, including girls who have not yet had their first menstrual period. Post-treatment assessment of ovarian health is also available, and things like blood work can be useful for that, as well as ultrasounds to measure follicle counts. So there are a variety of tests that can be done to give an idea about that. And some patients may consider post-treatment egg freezing. This can be considered for girls who are usually older teens or young adults. They have to be motivated, as this is also an IVF cycle, and this requires invasive procedures, transvaginal ultrasounds, taking medications daily, and retrieval procedures. So they need to be ready for that if they decide to go ahead. Next slide. So we'll talk a little bit about wellness and metabolic health, and then we'll be opening up very soon for questions. Next slide. This is just a map to give you an idea about the prevalence of obesity and the challenges that we face on a national basis in the US. As of 2020, this map was supplied by CDC. I had an old slide from about 2011, and I can tell you that the majority of the states that are orange now used to be yellow, and the majority of the states that are medium red now used to be orange. So this is an emerging issue in the United States that impacts, of course, our kids with brain tumors, but also impacts a lot of people. Go ahead to the next slide. Generally speaking, the American Heart Association and the CDC have made recommendations for the amount of physical activity that we should strive to achieve. I say strive to achieve because I know that I don't always meet these mandates, but they're looking for 150 minutes of moderate exercise or 75 minutes of vigorous exercise per week for adults, as well as some strength exercising twice a week. And for kids, they're really looking for an hour every day. And I emphasize that this should be fun, age appropriate, and for kids who get bored, sometimes having varied activities is beneficial. Next slide. People ask me about the best diet they can follow, and this is my personal favorite set of dietary recommendations because it is deceptively simple, but really, I think, very, very excellent recommendations. So this is called the plate method. A person who's practicing this either physically with a divided plate or in their imagination, as is depicted here in the picture, divides their plate in half, and they divide 1/2 into 2 quarters. They can put grains and starchy vegetables on 1 quarter. They can put lean protein on the 2nd quarter and have their non-starchy vegetables on the other half of the plate. This allows for food selection both in the home and outside the home, as well as when you're visiting with family members and friends, and can be applied really in almost any setting. It's also simple enough to teach a pre-adolescent or adolescent, when I like that, and it does not require any really particular measuring or counting or apps. You know, some people get really into measuring and counting in apps, but this does not require a lot of math or a lot of measuring. Next slide. In order to be successful with the plate method, I have a few recommendations that are specific for plate method, and then some things that are just, I think, good practice overall. Trying to switch as much as possible of our drinks over to water, or using something like fruit, or cucumbers, lemon to make water more tasty and appealing. Trying to use an activity tracker, considering making that a game with the family members so people can have cheerful competition with each other around that. Specifically for the plate method, I recommend that people put the veggies on the plate first, because if we put our starch and our protein on the plate first, we may not have space remaining. The real estate may be occupied and we won't get half a plate of veggies. So go ahead and get the half a plate full of veggies first. have one carb choice per meal. It's very hard to put two carb choices on the plate at the same time. So what I mean by that is beans or cornbread, garlic bread or pasta, but not both choices at the same meal. Keeping second portions on the veggie side only. So I think that can be very helpful if you're still hungry after you finish your plate. That's fine to have a second portion, but it should come onto the veggie side of the plate. Specifically for our brain tumor population, especially people dealing with hypothalamic obesity, I think avoiding processed foods, limiting eating out, trying the occasional plant-based meal, and then especially keeping a very regular schedule of meals and snacks. And I think this is important to address the issue of food security and anxiety around meals that can occur with hypothalamic obesity. Next slide. I did put in a slide on hypothalamic obesity. I think the families who or patients who perhaps are living with this will be very familiar with what I'm talking about. And folks who have a child or themselves have a brain tumor that is in a different tumor location and have not addressed this personally may not know what I'm talking about. But there's a part of the brain in the hypothalamus that's specifically responsible for us interpreting how much food intake we need to maintain our energy needs and when we are hungry and when we are full. And this part of the brain can be injured by a brain tumor. Additionally, the same part of the brain influences the amount of energy that our body burns off every day. It influences the rate that the metabolism runs at, or essentially how hot our furnaces burn. So people with hypothalamic obesity have problems where they don't burn off as much energy. They may also have other associated issues like narcolepsy or daytime somnolence, where they're very sleepy in the daytime and less active. They can have decreased physical activity because of physical limitations, potential neurological disability, or even issues like blindness. And then they can also have abnormal neuro and hormonal signaling. So that's going back to the part where they can't feel when they're hungry and when they're full. And things like insulin secretion can also be altered in a way that promotes weight gain. It's a complicated disorder, but all the roads sort of converge to promote weight gain that's not desirable. And it's a medical disorder. This is not a weight gain that's anybody's fault. Next slide. There we go. There are a lot of treatments that have been proposed for this, and they include stimulants, synthetic T3, which is a form of thyroid hormone, numerous medications that I've listed there. Unfortunately, none of these medications have been shown to be highly effective and have a durable result that lasts for 6, 12, 24 months in randomized controlled trials. Some drugs are still being studied. There are clinical trials that are still collecting data and will be published in the future for several medications, including some oxytocin analogs, Tesamet, and GLP-1 agonists. But I think overall, medical management for a child who's dealing with hypothalamic obesity has to be individualized. And my experience in the past 13 years is that while none of these agents are extremely effective across the board in big populations of patients, some of these agents can be effective in select patients. So sometimes it is worth working closely with your doctor to consider the risks and benefits and to consider what you might want to try out, knowing that it might be helpful or it might not. Next slide. This was just a little graphic I put together to think about how we define success in hypothalamic obesity, because it is a really distressing problem for kids who are dealing with it and for the family members who live with them. In the center, I put our family goal setting. And so that's not setting a weight goal. That's setting goals around our exercise habits and the foods that we offer at home and how we manage the situation. So goals that are smart and that we can succeed at. And I think the important elements here include things like food choices, reducing processed foods, reducing eating out, and simple sugars, simple carbohydrates. Food security, having a regimented schedule so that the child knows exactly what and when to expect in terms of their food. There's a potential role for medication, although I probably should put a star by medication because we really have limits as a medical community in terms of effective medications for this condition. Exercise is important, sleep, and sometimes even considering medication or other interventions to address sleep problems like narcolepsy or sleep apnea. And pantry locks are controversial. Some people really cringe when they hear about them or think about them. But if applied in a non-punitive way, they can really be life-changing for some patients and families. So I think there's something that you might consider and talk with your doctor about, particularly if you're really struggling. Next slide. So again, I want to thank you for the opportunity to be here. I encourage you to talk to your doctor if you think your hormones or your child's hormones could be abnormal after brain tumor treatment. Make sure you talk about your cancer history and history as well in your family, both of cancer, but also of relevant metabolic conditions and other relevant health conditions. And consider asking your oncologist about getting a survivor health care plan if you don't have one already, so that you have a roadmap for survivorship and in your future health care once oncology care ends. And thank you again.
Thank you, Dr. Patterson, for that excellent presentation. I'm Kathy Riley, Vice President of Family Support for the Pediatric Brain Tumor Foundation. I'll be introducing our parent panelist, Amy Wood, but I want to remind you we'll be taking questions from all of you. So if you have a question in mind, I see we've already received a few. Please type your questions into the Q&A feature at the bottom of the Zoom screen. Amy Wood is Executive Director of the Raymond A. Wood Foundation and mom to Alex, a pediatric brain tumor survivor. Amy started her career as a field producer on the Washington, D.C. political beat, and then moved on to produce videos and television for clients, including PBS and the US Navy. She then transitioned to web and marketing design, where she served as an advertising agency art director and tourism marketing manager before launching her own boutique design studio focused on helping small businesses build their brands. In 2015, Amy's son, Alex, was diagnosed with a craniopharyngioma brain tumor. She co-founded the Raymond A. Wood Foundation in honor of her son. Amy currently serves as executive director of the foundation and considers this the job she never applied for, but is the most passionate about. So welcome, Amy, to our panel discussion, and Dr. Patterson. It's great to have both of you here for this. So I will start. We're receiving a lot of questions in the Q&A feature. So Dr. Patterson, I'll start with you. A question that we have is, can you speak a little bit to your experience with growth hormone excess in children with a hypothalamic low-grade glioma? Have you treated children with excess growth hormone, and can you talk a little bit about that treatment?
Yes, that's a really interesting phenomenon that I think was probably first described in the medical literature about 7 or 10 years ago. And I have seen that in a handful of patients with low-grade glioma. I don't seem to see it very often in any other tumor types, but the basic problem is that the normal brake pedal on growth hormone secretion is broken, and they seem to produce more growth hormone than would be expected. The findings are often associated with hypothalamic obesity, but not always. And it can also be associated with precocious puberty, but again, not always. The growth hormone excess can occur independently. I've had variable experiences with that. There is no well-established, well-studied, FDA-approved treatment for growth hormone excess in the age group that seems to be impacted by this. In my experience, it's usually younger children under age 10. And so I have both used some of the adult treatments that are typically used for growth hormone-producing tumors, which this is not a growth hormone-producing tumor. It's just that it's permissive to allow growth hormone secretion. I've used those adult medications sometimes in this population. And I've had other families who chose not to. They were nervous that these drugs were not well studied in young children and decided not to do treatment. And I've seen growth hormone excess resolve with medication, but I've also seen it resolve with treatment of the primary tumor. So sometimes the growth hormone excess could improve as they receive their chemotherapy to treat the tumor itself. But it is a it's a common, uncommon problem in low-grade glioma.
Great, thank you so much for addressing that. Amy, we had a question come in at registration that I'd love for you to take a few minutes to share a little bit from your experience as a parent. But what advice can you provide on managing diabetes insipidus in your child?
Well, that's definitely, there's a long answer, so I'll try to keep it in a nutshell. But my son in particular has a dipsic diabetes insipidus, so he has no thirst sensation. So he couldn't use thirst to indicate whether, he was parched or dry and his sodium might be high. And then we had a lot of problems with lower sodium. So a lot of times, conventionally, we would use weight. So we do a dry weight in the morning to see what his weight was, and then check it throughout the day. So if his weight was extremely high in the morning, we knew that he had more water or less. If his weight was, low in the morning, we knew that he had less water on board, and so that he might need more medication and more fluids. And then if it was a pound or two higher, we knew that he might have too much water and we'd hold his fluids. We started the foundation around testing blood sodium at home with a handheld blood analyzer that's a hospital grade device, but that's really useful in extreme cases where you just are in and out of a lab, which we were 2 or 3 times a week to test sodium because we just couldn't gauge it. So it's tricky. It's a lot of working with endocrinologists. Some people just don't respond to twice daily dosing, 12 hours apart, because the desmopressin, the medication, may work differently day to day, which happens in our son. So sometimes on the same dose, he'll retain water and the sodium will go down. Sometimes he will have water, fluids come out all day long. So that was tricky for us. So it's always kind of a moving target, but over the years, we've gotten it a little more down to a science than early on.
Great, thank you, Amy. We've received a question that I think would be wonderful for both of you to provide some insight with your different perspectives. And Dr. Patterson, I'll start with you, and then maybe Amy, you could provide some comment from the parent perspective as well. So is it important to be seen by an endocrinologist with experience with brain tumor and cancer survivors at a major medical center, treating a major medical or treating center rather than a local endocrinology practice?
Well, that's a really good question. And one of the challenges in my profession is access to endocrine care, not even necessarily access to highly specialized care at a major cancer center, but just simply access to a pediatric endocrinologist at all. The majority of the United States is really very underserved for pediatric endocrine care. So I do think, depending on your geography and depending on what is available to you, you may be best served seeing someone who has extensive experience working with these patients. They'll be very familiar with current guidelines and have a lot of individual professional experience taking care of patients to give you the best care. But if you can't, I think you can still get good care with a pediatric endocrinologist. I would recommend, if you have many of the common risk factors that I talked about in the slides earlier, that you consider consulting with a pediatric endocrinologist, as my general experience has been that oftentimes your other doctors, your pediatrician, your oncologist, they may be focused on other issues, not as much on the endocrine issues. And so, meeting separately with an endocrinologist affords special time just to focus on those issues. So certainly a subspecialist, if you have one available, but if you don't, a general pediatric endocrinologist can do a great job for you. And that's where that survivor healthcare plan is helpful, because it can tell your endocrinologist what treatments that your child or you received, and it can tell the endocrinologist what things to look out for.
I agree. I think I would just add that if you have indications like hypothalamic obesity, which is extremely challenging, that even if you're seeing an endocrinologist that maybe isn't in a big hospital, there are a lot of endocrinologists at the big hospital systems that are willing to collaborate. So maybe your endocrinologist could reach out. We've had people contact the foundation, asking questions, and I think everybody's willing to work together on these harder issues. So if you can't access it, just see if your child's endocrinologist would be willing to collaborate, and certainly can find somebody to help out with some of the tougher things.
Mm-hmm. Amy, I agree. We're kind of a tight-knit, small community.
Yeah.
So, those communications really are common in our field, and we expect and welcome them.
Wonderful. Thank you. Thank you both for sharing your perspectives on that. We had another question come in specifically about diabetes. Dr. Patterson, I'll send this one your way. Is it possible for a child to have both type 1 and type 2 diabetes?
Oh, well, that's an interesting question. Not as much a brain tumor question. So type 1 and type 2 diabetes really refer to diabetes mellitus. So we're talking about high blood sugar, which is totally different than diabetes insipidus, which is what Amy was talking about earlier when she was talking about having to monitor sodiums and water balance and weights for her son. And type 1 diabetes is an autoimmune condition where the immune system attacks and destroys the pancreas, rendering it incapable of making insulin. Type 2 diabetes is a complex metabolic disorder where youth or adults can have issues of insulin resistance, but also some relative insulin deficiency. Generally speaking, a person who has type 1 diabetes and who cannot make insulin doesn't necessarily have to also have insulin resistance, but it is possible, particularly if they have genetic or family history risk factors for type 2 diabetes, or if they're dealing with issues of overweight and obesity or sedentary lifestyle, they can be insulin resistant at the same time as having type 1. I would usually characterize a patient like that, though, predominantly as a type 1 diabetic.
Thank you. We also had a question come in at registration that I would love to Dr. Patterson ask you to address. So it's talking about long-term issues. So what are the long-term effects, if any, of hormone replacement medication?
Mm-hmm. Oh, yes, that's a very good question. And I think I'm going to answer it from the perspective of kind of sex hormone replacement medications. I think when many people talk about hormone replacement, they're really referring to estrogen replacement, progesterone for women, or testosterone for men, as opposed to other things like thyroid and growth hormone. Generally speaking, in our pediatric brain tumor population, when we're talking about using these medications at a young age in children who truly have a deficiency, there are not a lot of long-term concerns about negative consequences, because whether it's a boy or a girl, the usual physiologic expectation would be that they would have plenty of estrogen, progesterone for a girl, or testosterone for a boy when they're in their later teens, 20s, even their 30s. As we age, the potential risks or negative impact for hormone replacement, the risk-benefit balance changes. And as women approach the natural age of menopause in their later 40s up to early 50s, we may become more concerned about the risks long-term of continuing estrogen and progesterone supplementation, and particularly as it would relate, for example, to breast cancer risk or uterine cancer risk. For males, the same is true. Higher doses of testosterone, longer-term treatment through aging could be potentially associated with increased risk for prostatic cancer or elevated risk for cardiovascular disease. But it's a much lower concern in our younger population, particularly if the patient has been deemed truly deficient. I'm very cautious about giving testosterone to older teens and young adult boys who have borderline low levels or low normal levels because of these risks. But when the levels are definitively low, unarguably low, I think that the benefits far outweigh the risks.
Great, thank you. We have another question that I think I'd love to hear from both the provider and the parent perspective. And that question is, how soon after starting or finishing chemotherapy would you recommend being seen by an endocrinologist?
Amy, do you want to go first on that one?
I can't really answer that because my son didn't have chemo, and most cranios don't actually. So I'll leave that one to you.
Okay, no problem. Yeah, no, that's a good question. I think it depends so much on tumor location. So patients with tumors like craniopharyngioma, which may not be treated with chemotherapy, but sometimes there are medical treatments that are offered, or a germ cell tumor, which definitely would receive some chemotherapy and radiation. Those tumors that have that location in the pituitary and hypothalamus probably need an evaluation around the time of tumor diagnosis, very early in the treatment process. For other tumor types that don't directly impact the pituitary and hypothalamus, so for example, medulloblastoma or ependymoma, I tend to see those patients around the time that they are about 1 year post completion of radiation therapy. However, the oncologists that I work with do an excellent job obtaining some endocrine screening labs every few months in that during treatment and in the first year after treatment. So they'll refer them sooner than 1 year post radiation and chemo if they notice a problem in the screening labs.
Great, thank you. Thank you both. One final question, I think, is just a point of clarity from the presentation, Dr. Patterson. The idea of secondary cancers and growth hormone, and could you talk just briefly again about that and the relationship, between those?
Oh, absolutely. Yeah, so early on, they were doing studies where they were monitoring survivors of pediatric cancer, including pediatric brain tumors, over the course of many years through something called the Childhood Cancer Survivor Study, where they've studied literally thousands of survivors of pediatric cancer, including many brain tumor survivors. And what they observed was that there was no increased risk for recurrence of the primary cancer. So if you had medulloblastoma and you developed growth hormone deficiency and you received growth hormone therapy, the chance that your medulloblastoma came back was not elevated, or whatever tumor type you had. For the secondary malignancies, what I mean by a secondary malignancy, or sometimes it's called a second neoplasm, that's developing a new type of tumor that you never had before, but after treatment for a first tumor type. And early on, there appeared to be a signal where there seemed to be a 2 to 3-fold increase in the rates of these second tumors. For brain tumor patients, the second tumors are usually gliomas, which occur early, or meningioma, which can occur late, 10, 20, 30 years after treatment. There appeared to be a 2 to 3-fold increase in these second tumors. However, on subsequent analysis, what we found was that the radiation therapy that was causing the growth hormone deficiency was also probably the main driver of the second tumor development. So while people with growth hormone deficiency were developing a little more second tumors, they were probably developing them because they had radiation, as opposed to because they had growth hormone treatment. So I feel really pretty good giving growth hormone treatment to my pediatric brain tumor survivor population, something I do every day of the week. So I feel that it's largely a benefit, but that is a very, very common question.
Wonderful. Thank you so much for that clarification. We have unfortunately reached the end of our time. We have a lot more questions we wish we could have answered, but please feel free to stay in touch with us and send us any questions that are pressing that went unanswered today. I want to thank Dr. Briana Patterson for her time today, for sharing her expertise with us. Thank you, Amy, for providing meaningful and personal insights from your journey with Alex. I also want to thank you, our attendees, for your participation and your thoughtful questions. Amy, I'd like to turn it over to you for just a minute here as we finish out the webinar to just tell us about the work of the Raymond A. Wood Foundation.
Thank you, Kathy. Yeah, I just wanted to say, especially seeing a lot of these questions come in particular to hypothalamic obesity, the Raymond A. Wood Foundation does provide a lot of educational resources around some of the challenging endocrine issues that come from these tumors, specifically diabetes insipidus and hypothalamic obesity. You can find some recorded webinars and even our conference recordings on our YouTube channel. So just search Raymond A. Wood Foundation on YouTube. And we also host a yearly conference that's mostly around these issues that were discussed today. So we welcome anyone that has any questions or wants access to resources you can email me at amyw@rawoodfoundation.org, and I'll be happy to direct you. But we work in patient advocacy. We provide education and resources, research development. We have monthly caregiver support groups. And as I mentioned, our yearly family conference. So thank you so much, Kathy and the PBTF and Dr. Patterson for all of your excellent information. It was our honor to be here today.
Thank you, Amy, and to the Raymond A. Wood Foundation for partnering with us today on today's webinar. The PBTF is here to help you no matter where you are in your journey. Please reach out to us for support at the contact information on this slide. We'll be sending you a link to the recording of the webinar today, and we'll send you the slides at the email that you registered with. Thank you for attending the webinar. And again, please reach out to us if there's anything we can do to help your family. Have a great day. Bye.